As healthcare workers are presented with scarce resources, they will be called upon to improvise and ration the materials available. A discussion paper from the National Academy of Medicine advises strategies for approaching these challenges, including substitution, adaptation, reuse, and reallocation. Some of these challenges will require creative solutions. With inadequate supplies of medications or supplies, consider others that may be equivalent or near equivalent. Consider adapting equipment for alternative purposes, such as using an anesthesia machine as a ventilator. Many single-use items, such as ventilator circuits or tubing, may also be in short supply and may be reused following appropriate disinfection or sterilization. Finally, there may be circumstances in which one must consider the reallocation of resources such as ventilators or ECMO from one patient to another who has a higher likelihood of benefit. The need for ventilators will be a significant challenge in the COVID-19 pandemic. The American Hospital Association estimates that as many as 960,000 patients will require ventilator support. Reports of the experience with COVID-19 in Italy reveal that patients required mechanical ventilation for up to 15 to 20 days. Currently, the U.S. potentially has 200,000 ventilator units available for use. This includes approximately 62,000 full-featured ventilators and approximately 98,000 older, more basic ventilators, and approximately 12,700 ventilators in the Strategic National Stockpile, which can reportedly be available within 24 to 36 hours of request. This supply may still not meet the need, and improvisation and difficult decisions will need to be made. Ventilators will be in short supply if the COVID-19 pandemic affects the population as it is expected to. With 200,000 ventilators available in the U.S. and an estimate that nearly 1 million patients could require ventilator supports, clinicians will face multiple patients presenting simultaneously requiring mechanical ventilation and not enough of a supply. A 2006 study published in Academic Emergency Medicine demonstrated a simulation of a single ventilator modified to ventilate 4 simulated lungs for 12 hours. Following the 2017 Las Vegas mass shooting, this was successfully performed in the emergency department at Sunrise Hospital in Las Vegas using 1 ventilator for 2 patients. The use of 1 ventilator to ventilate more than 1 patient is clearly off-label use and should be considered a temporary measure for extraordinary circumstances. There is a risk for cross-contamination when using this approach. Patients should have similar lung sizes and airway resistance to avoid unequal ventilation. Additionally, tubing to each patient should be the same length. This is clearly a temporary measure for a catastrophic situation, but could prove to be useful as emergency departments across the nation face a surge of COVID-19 patients requiring mechanical ventilation. Photos shown here are from the 2006 simulation study. 4 sets of ventilator tubing were connected to a single ventilator using 2 flow splitters, as seen in the left photo. Flow splitters were constructed of 3 Briggs T-tubes and connection adapters with the valves removed. The photo on the right demonstrates the entire configuration, including lung simulators. When performed in Las Vegas in 2017, Y-tubing connected 2 sets of ventilator tubing to 1 ventilator, and the tidal volume was doubled, allowing 2 patients roughly the same size to be ventilated by 1 machine. Many states and organizations have policies and guidelines in place regarding the allocation of scarce resources. These are for extraordinary situations such as the ones we are facing with the current COVID-19 pandemic. Beyond the lack of ventilators and ECMO, we may also face shortages of medication and blood products, as well as a lack of devices such as IV pumps and hemodynamic monitoring supplies. In general, a triage officer or triage team should be in place to make assessments in the allocation of supplies rather than leaving it to the team caring for these patients on a daily basis. In a March 23, 2020 article in the New England Journal of Medicine discussing the fair allocation of scarce resources in the COVID-19 pandemic, the authors provide recommendations for allocating resources. It says that we should aim to maximize the benefit of care to save the most lives and maximize prognosis. Patients should be treated equally. This is not a situation for first-come, first-served allocation. For a group of roughly similar patients, random selection is really preferable. There should be no difference in the allocation of resources between patients with COVID-19 and those with other conditions. The authors suggest that those participating in COVID-19 research trials should receive some priority as a reward for their contribution. Finally, the scarcity of supplies will affect all patients. Fair allocation of resources, prioritizing the value of maximizing benefits is the goal. So how to make the decisions about which patients should get what treatment and equipment. Patients are first screened for exclusion criteria or conditions with immediate or near-term likelihood of mortality. These patients should receive palliative care. Patients who are not excluded are then assessed with the Sequential Organ Failure Assessment, or SOFA, score, or other clinical criteria to determine the allocation of resources. Patients are reassessed regularly to determine whether reallocation of resources is appropriate. Transparency and outreach with the public should be in place to make it clear that the standard of care will be different during this pandemic and that criteria are in place to avoid personal preference. Preparing for the worst. Healthcare systems across the U.S. are already facing challenges with the COVID-19 pandemic, particularly in the availability and allocation of testing and PPE. Availability of medications, ventilators, and intensive unit beds will be inadequate to meet the need based on current models. Healthcare systems need to work now with their ethics teams, physicians, and staff to ensure that the protocols are in place for answering the difficult questions and allocating scarce resources. We can look to the experience of China and Italy over the past month to see what choices will need to be made by us very soon. Healthcare systems across the U.S. are already facing challenges with COVID-19 pandemic, particularly in the availability and allocation of testing and PPE.